So hello everyone, my name is Sarah Eisinga and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. I'm pleased to welcome all of you to today's conference session on marginal zone lymphoma. We appreciate those that are able to attend live today to learn more about the disease-specific biology and diagnosis of this lymphoma subtype. This presentation will highlight novel research and treatment options that are accessible to lymphoma patients across Canada. Now, before I introduce today's speaker, I'd like to provide some guidance about the Zoom software for this session. This virtual software does not allow you to share your video or your microphone. If you have a question, please save it for the indolent non-Hodgkin's lymphoma Q&A session following this presentation. And this is where you can ask your questions to the presenter live. I would now like to introduce and welcome you, our speaker, Dr. Gwyn Davies. Dr. Davies is a born and raised Calgarian who completed her medical training between Calgary and London before completing lymphoma fellowship at the Tom Baker Cancer Centre. She worked in Thunder Bay as a community hematologist for several years while completing her Master's of Public Health through Harvard, then moved south in the early pandemic. She now practices at the Juravinski Cancer Centre in Hamilton, Ontario, focusing on lymphoma, autologous transplantation, and CAR T-cell therapy, and recently became the Lymphoma Fellowship Director. Her research focuses on clinical outcomes of patients with lymphoma and improving hematology residency education. We thank you very much for joining us today, and then I'll turn over the presentation to you, Dr. Davies.
Right. Thanks so much for that introduction, Sarah. And thank you so much for inviting me to speak at this conference today. These are my disclosures. So what are we going to cover today in this talk? So we're first going to talk about the characteristics of marginal zone lymphoma, since it's such a kind of wide and varying disease. We'll talk about the different subtypes, because there are quite a few different subtypes of marginal zone lymphoma. We'll talk about appropriate staging and investigations to work up patients, initial and treatment and relapse, as well as challenges and unmet needs. So when we look at the landscape of lymphoma, we know that this makes up 40% of new hematologic malignancies each year. So you can see more commonly we have non-Hodgkin lymphoma, and within that B-cell is more common than T-cell. And we'll talk about precursor versus mature B-cell when we actually sort of understand how lymphoma develops. So within mature B-cell, there's both indolent and aggressive lymphomas, and marginal zone lymphoma is the second most common type of indolent B-cell lymphoma. So when we're talking about indolent lymphomas versus aggressive, what we usually are referring to is that indolent are more frequently slow growing. So they don't necessarily need to be treated right away when they're identified, depending on kind of the stage and biology. But also they're frequently incurable. So people live for a really long time with the disease, but they can have relapses over time. We know that over time, certain types of lymphoma are decreasing in frequency. However, marginal zone lymphoma is actually one type that is increasing, and that's potentially because of the infections or autoimmune conditions that it's related to. So this is an old picture, but essentially it shows the distribution of lymphoma. So you can see that most commonly we have diffuse large B-cell lymphoma, which is the most common aggressive type, followed by follicular lymphoma. However, there are still good proportions of MALT lymphoma, which is one of the types of marginal zone lymphoma. And then a lot less commonly, we have splenic and nodal marginal zone lymphoma. So when we talk about how a lymphoma develops, we know that B cells are first made in the bone marrow. So you can see they start out as what's called a progenitor B cell. They grow up within the bone marrow, and then they actually get released out into the rest of the body. So they go to what's called the peripheral lymphoid tissue. And so when they get there, what happens is that there's sort of these young, naive B cells, and then they're exposed to an antigen. So that's a stimulus. So that can be something like a bacteria, an infection. Sometimes it's even their own cells, and they can develop sort of an autoimmune condition. But once they're exposed to that antigen, B cells grow up and they start to undergo a lot of different changes that make them sort of specific. So if you had an infection, it would be that you're making B cells that specifically will fight or counteract that antigen. And when that happens, they actually go to a place called a germinal center, which is within a follicle. So, and then once they're in that follicle, essentially they're working to become more specific to that infection or that antigen. And after they've developed the ability to fight that or make antibody against it, they can go out into a specific area called the marginal zone, where you can have memory B cells. So you can see that on the far right, and that's actually where marginal zone lymphoma can come from. So this makes up about 7 to 10% of mature non-Hodgkin lymphoma. So again, it is the second most common type of indolent, but certainly it's much less common than follicular lymphoma. There's multiple different subtypes, and actually this was just updated this past year because they have made some changes to the classification system. So the most common type is extranodal, so outside of the lymph nodes, marginal zone lymphoma of the mucosa-associated lymphoid tissue. So essentially what this is we have our kind of standard lymphoid sites that you think of, like your lymph nodes, your spleen, but then we actually have kind of secondary lymphoid tissue throughout our body in areas where it's moist. There's lots of antigens like your nose, your gut, where there's going to be a lot of different exposures. And there's B cells and T cells that kind of hang out in that area, and they look for infections or antigens to react to. So you can imagine if you had a chronic infection or an immune condition that was stimulating all those B cells over time, that could eventually lead to them sort of starting to grow on their own or become autonomous and turn into a lymphoma. So that's what happens with this extranodal marginal zone lymphoma. It's frequently called MALT, so I'll kind of use the two terms interchangeably, which is what happens in the literature as well. The second subtype listed here is primary cutaneous marginal zone. So that's where people actually just get lesions on their skin. We know that those individuals do very well. So it's actually been separated out from MALT, which is a new change up this year. The next most common type is splenic marginal zone lymphoma, followed by nodal, which is the least common type in adults. I'll just briefly mention pediatric marginal zone lymphoma. So this is commonly stage 1, involving the head or neck, as expected based on the name. It's seen in children, and generally these individuals do very well. So in marginal zone lymphoma, as with most lymphomas, we know that the incidence increases with age. This is more commonly seen in men, except for certain types of extranodal, which can occur in the salivary glands or the thyroids, because that's related to autoimmune conditions that are more commonly seen in women, like Sjogren's syndrome, where people have dry eyes and dry mouth, Hashimoto's thyroiditis, etc. So again, we know that this is related to chronic infections and autoimmune conditions, because again, they sort of have these drivers where they're constantly stimulating the white blood cells, and that can lead to sort of overgrowth over time, and then they can start to grow on their own, and that's where the lymphoma develops. Again, they're frequently slow growing or indolent. We do know, however, that approximately 20% of marginal zone lymphoma patients kind of have more bad behaving biology, so they progress sooner than we expect, or they don't respond to frontline treatment quite as we expect as well. So we do know that those individuals kind of struggle a bit more with their disease over time. So talking further about extranodal marginal zone lymphoma, or MALT, so this makes up about 70 cases of marginal zone. This can either be in the stomach, which is the largest category, or non-gastric, which is about 60 to 70%, and that includes kind of ocular, thyroid, breast, lung, gut. Again, really anywhere that you have a proliferation of lymphocytes or B cells. So the symptoms are generally related to the location. So for instance, in the stomach, individuals can have pain or reflux symptoms. They can have difficulty eating. They can have bleeding in their bowels. In the breast, they can have a lump. Thyroid, they can have a lump. If it's ocular, they can have redness or a lump. So it's really particular to where that marginal zone lymphoma is growing. We know sometimes that individuals can have extranodal marginal zone lymphoma pop up in one location. It can be treated, and then several years later, it can pop up in a different location. And actually, if those are both kind of localized occurrences, we can kind of treat them separately. So kind of manage it as it comes, rather than having to turn to sort of more systemic or whole body treatment at that point. We know that patients with gastric MALT or extranodal marginal zone lymphoma generally do very, very well. So with frontline treatment, responses last usually for over 10 years. So over 90% of people are living without evidence of their lymphoma at 10 years. The outcomes are still very, very good for non-gastric MALT. They just can have a slightly higher risk of relapse over time. So this is just an example of different sites that can be involved with the marginal zone lymphoma. So on the top left is stomach. So there can actually be quite a nodular growth pattern in the stomach that we can see. It's very common to have multifocal or multiple lesions in the stomach when they're seen, which is why they recommend against, for instance, surgically excising the lymphoma or trying to remove it, because it would require kind of removal of large parts of the stomach, and we have other very effective methods of treating it. In the bottom is the ocular adnexa, so you can see kind of lump and redness that's there. And then in the top right is a CT scan of the lungs, so you can see that there's normal lung tissue, and then in the one area there's an obvious mass that shouldn't be there. And again, symptoms are very dictated depending on where the lymphoma is coming. Although there are certain types, like the lung, for instance, where frequently they're found kind of incidentally. So patients will have a scan for a different reason, and then they'll see that they have nodules and go and biopsy them, and will actually find marginal zone lymphoma at that time. So that really highlights how slow growing this can be, that essentially they're presenting asymptomatically. So we've learned a lot more about different infections and different genes that can be involved in marginal zone lymphoma. We would call this a very heterogeneous, so lots of different genes that can be affected. So just looking at this picture, so on the left side, it's just talking about different etiologies. So you can see at the top in the stomach, there's an infection called Helicobacter pylori. So that's the infection that we talk about that's associated with gastric marginal zone. And so it's very common in certain parts of the world. It can cause reflux, and it's an infection that can last for years and years. So sometimes individuals don't even know if they've been infected for decades, but it can slowly be causing these changes in their stomach. There's other infections like that can exist in the lung for long periods of time. There's even a type of chlamydia that we know is associated with that ocular disease, as well as autoimmune diseases, so specifically Sjogren's and Hashimoto, which can be associated with those types of extranodal. And even Borrelia burgdorferi is actually the infectious agent that causes Lyme disease. So we know that there can be an association between that and skin. So actually, on the flip side, again, we know that there's all these different genes that can be mutated. So what you can see is on the right, there's a list of all these different things. And unfortunately, we're not able to test for all of those when we look at people's tissue or do blood testing. But now that we have access to more DNA sequencing, we know that there's all these different things that can happen that can sort of support lymphoma growth. So there are things that prevent the cells from dying, that cause them to reproduce more frequently. And so, we have a much better understanding of sort of the biology of marginal zone lymphoma now than we did, for instance, 10 or 20 years ago. So the next most common type after MALT is splenic. So this makes up about 20% of marginal zone lymphoma. In this picture, you can see a very large spleen on the left side. So the spleen essentially extends all the way down the abdomen. So normal is up to 13 centimeters. So you can see this is quite large. You can imagine that this would cause problems like feeling belly pain, feeling full quickly because it's pushing on your stomach, weight loss. We also know that about 30% of these individuals will have abnormal antibody or immunoglobulin production in their blood when we check it, and 20% can actually have autoimmune symptoms from the disease. This is quite uncommon, and frequently these patients don't have sort of generalized lymph nodes. It's very challenging to get a splenic biopsy in certain cases because of the risk of bleeding or infection when you're essentially sticking a needle into a large blood-filled vessel. However, a lot of times we can actually make the biopsy based on looking at both the blood and the bone marrow, which are frequently involved. These patients sometimes don't need treatment for years and years and years, just because, again, they have an enlarged spleen, but they're not sort of bothered by their symptoms, which is, again, a bit different than the extranodal. Lastly, we'll talk about nodal. So this makes up 10% of marginal zone. This is more like a sort of classic indolent lymphoma that you would think about. It's frequently advanced stage. You can see an elevated lymphocyte count. They can also have spleen enlargement, lymph node enlargement. We know that these individuals do slightly less well during their cancer journey compared to the splenic or extranodal marginal zone lymphoma. Fortunately, though, B symptoms or constitutional symptoms, which are those things that we ask about at each clinic visit, like fevers, weight loss, and night sweats, are still quite rare because, again, these are still kind of more slower growing than their aggressive counterparts. So when we're making the diagnosis, we usually are starting with blood work. So on the blood work, we're looking for whether they have an elevated white blood cell count or lymphocyte count, which can sometimes indicate that there's circulating marginal zone lymphoma cells. We want to know whether they have low hemoglobin, low platelets that might be from disease causing a large spleen or taking over the bone marrow. We can also do an infectious workup, like looking for hepatitis when we first see patients that can sort of indicate a driver for the disease. One thing that we commonly do is a bone marrow biopsy, so that's important for staging, but also helps for diagnosis in certain cases such as the splenic marginal zone, which might be a bit more challenging to get a sort of primary biopsy in. We can do a lymph node biopsy, and again, normally we would want either an excisional biopsy where we remove the entire lymph node, or a core biopsy where we're taking actually several punch cores out of the lymph node rather than doing a fine needle, which is where we just stick a needle in and suck some of the cells out. When we're talking about scans, there's certain indications for doing an ultrasound, such as if you're following patients over time and you just want to see that their spleen is shrinking. Generally, when these patients are diagnosed, we'd be doing a full body CT scan because we want to see kind of the full extent of their disease. There's a bit more controversy with PET scans. So a PET scan essentially is where individuals receive an injection. It's actually a sugar or a glucose that's attached to a radio tracer, and then that circulates throughout the body. And so just like normal cells, cancer cells need calories to grow, and so they actually take up the sugar, and then it lights up on a PET scan, and we can see exactly where the disease is. So you can imagine that if you have more of a slower growing lymphoma, it wouldn't be taking up quite as much of the sugar, and so the PET scan wouldn't be as good at identifying all the different sites. So PET scans are less commonly used in marginal zone lymphoma. They're not great at looking at certain sites like extranodal sites and bone marrow involvement, but we do know that they're actually more useful in looking at certain types like nodular marginal zone lymphoma, nodal marginal zone lymphoma. And also they are helpful if we're concerned about a transformation to aggressive types of lymphoma, which can happen in some patients with marginal zone lymphoma. Lastly, if we need specific types of tissue, sometimes we'll refer them to other specialties like ENT or ophthalmology. Frequently, again, endoscopy is needed to look in the stomach or in the small bowel, or even a targeted biopsy. For instance, we might send them to dermatology or plastics if there's a skin lesion that's concerning. So this is just an example of what blood involvement with marginal zone lymphoma looks like. So to orient you, again, this is a peripheral blood smear. So this would be taken from a vial that would be removed from an individual's arm. The red cells are red blood cells, and then the large purple cells are lymphocytes or B cells. And so normally these would be very circular around. And so what you can see in these individuals is that they have these little fingers coming off them. And so we actually call these villus lymphocytes. So this is very pathognomonic for certain types of lymphoma. So if we were to see this on the peripheral blood smear, then we could do a special type of testing called flow cytometry, which actually sorts the white blood cells according to proteins on their surface. So we can see if there's a bunch of white blood cells that all look like copies of each other that shouldn't be there, and that can indicate to us if there's concern for lymphoma on the peripheral blood. So this is two pictures comparing bone marrow biopsies in someone with a normal bone marrow and someone with lymphoma involvement. So what you can see on the left is that there's the pink bony trabeculae. So that's actually the sort of structure or scaffolding for the bone marrow. Our bone marrow is not, our bones are not solid, otherwise they'd be too heavy. So in between the scaffolding, we have all these different cells that you can see, all different colors. And there's also lots of fat particles as well, and that increases with age. So on the right panel, you can see that there's kind of a large area where there's very little fat. There's lots of these little purple cells. So this is actually demonstrating lymphoma involvement on a bone marrow. So that special test, the flow cytometry, is something that we can do on bone marrow as well. And also on the solid part of the bone marrow, we can sort of cut it up and stain it, and we can see kind of where there's way too many of one type of cell. And so the stains can help us to identify what type of lymphoma it is. We can also do a special type of molecular or DNA testing on the bone marrow that can help to differentiate from other types of lymphoma, such as something called Waldenstrom, which can kind of look the same as marginal zone lymphoma on the bone marrow. And so that can help to tell us what exactly we're dealing with, which can guide management in frontline and at relapse. So when we're talking about lymph node biopsies, again, there are certain types of cancers where we can, just stick a needle in, take a few cells out, for instance, in thyroid or breast cancer, and have a pretty good idea what we're dealing with. But when we're talking about lymph nodes, they're very complicated structures that have specific architecture. So what you can see is that the lymph comes in at the top. So that's that afferent lymphatic. And then it's going all through the lymph nodes. So essentially, this is where your B and your T cells are exposed to antigens. So they come in carried by the lymph. And then they can react here. And if they need to make antibodies or grow into those more terminal B cells, then they can do that here. And then it's all carried out through this, it's called efferent lymphatic. And so you can imagine if you just stuck a needle in and took a few cells out, you might completely miss the part of the lymph node where that lymphoma was involved or where those abnormal cells are growing. So it's just really important to make sure that we have enough tissue that we can actually make a conclusive diagnosis of what we're dealing with. So when we talk about staging, this is sort of a different conversation than with a lot of solid tumors. So the most common type of staging in non-Hodgkin lymphoma is the Ann Arbor staging system. So it goes from stage 1 to 4. But we do know, again, in marginal zone lymphoma, that there's frequently bone marrow and blood involvement. So it's very common for these patients to just be stage 4. That has entirely different connotations than, for instance, lung cancer or pancreatic cancer. Again, we think of these individuals as still very treatable, but that we do know, again, that involvement outside of the lymph nodes is quite common, which makes it stage 4. Because there's a few more characteristics when we talk about gastrointestinal lymphoma or gastric extranodal marginal zone lymphoma, there's actually a different staging system, which is called the Lugano staging system, and it's on the right panel here. And what we're interested in knowing about that is is the tumor just inside the stomach? Has it gone through the wall of the stomach? Is it involving lymph nodes, and are those close or farther away lymph nodes? So there's just a few more characteristics that we take into consideration when we're doing staging for those gastric malts. And so there's other staging systems that can also be used, such as the TNM or Paris staging system, but this is the most common one that we would use for gastric malt. And so the next step, once we've kind of gathered all this information from baseline testing and from staging, is we can actually calculate risk scores. So we even, like, these calculators essentially exist on the internet. We can, input a few variables and sort of come up with whether we think people are low, intermediate, or high risk. So I just included the two most common ones that are used in marginal zone lymphoma. So on the left is the MALT IPI. So this was created based on information from 400 patients with MALT who received frontline treatment. And essentially the question was, what is the risk of the lymphoma coming back or progressing or having other events related to the lymphoma? And so you can see that just by inputting, age, whether they were 70 and above or under, if they had an elevated LDH, which is a blood test, and what their stage is, we can get information to gather that. And so again, that helps us to share information with patients about, what they can expect moving forward. For splenic marginal zone lymphoma, which is in the right panel, there's a score called the HPLL, looking at hemoglobins, platelets, their LDH, and whether they have extrahilar lymph nodes. And again, that helps us to put that into a risk calculator, and we can figure out if they're considered low, intermediate, or high risk. I should say that, these pictures here, they're called Kaplan-Meier curves. So these are kind of what researching hematologists stare at and analyze all day. And so just because you'll see them in a few later slides, I'll just orient you. So all patients start at the top, so 100% of patients are considered at the beginning. And then when patients have an event, they sort of drop off it. So that would either usually be progression or actually passing away. So we can see that over time, if you're in the low risk category, almost 100% of patients, stay at the top, stay on that line. So it stays very flat, and there's very few people having events. And then if you're higher risk, there's lots of people who are dropping off over time because they either have disease progression or have other events such as passing away. So again, that's just all those curves are showing. That's sort of how we compare between groups. So when we're talking about frontline treatment, there's, a lot of different options, and this is mostly related to what type of marginal zone lymphoma they have, where the extent of the disease is. So we do consider, this is one of the few where we actually would think about surgical resection for certain locations. So for instance, if there's, lung involvement and we're confident that it's just confined to one region, we'll sometimes remove that. Like I said, for skin, you can frequently remove those lesions. If you had involvement of your conjunctiva, of your eyes, your thyroid, a nodule in your breast. So it's really important in these situations to look at the biopsy afterwards or the resection afterwards. And you're wanting to see that there's sort of clear margins, which is where there's no evidence of the lymphoma still kind of overlapping with the edge of the tissue, where you think that there's probably some left behind. So if they've had a full resection, it's very reasonable to think about just watching at that point and seeing what happens, knowing that there definitely is a risk of relapse down the road. Whereas if you do have positive margins, we frequently think about giving further therapy at that point. There is an option for watchful waiting or active surveillance. So that's essentially where you just keep an eye on patients. We're seeing them regularly every 3 to 6 months. But because this is a slower growing lymphoma, sometimes we can actually get away for even years without needing treatment. We frequently use that more in advanced stage because, again, we don't think there's that chance of cure, and we know that intervening early with chemotherapy doesn't actually prolong their life. So if people are asymptomatic, then it doesn't really make sense to give them the side effects of chemotherapy by, treating them when they're otherwise very well. We know that it's very important to treat infections, and I'll talk about that a little bit more on my upcoming slides. Radiation is a very good option. So this is a lymphoma that is very sensitive to radiation, and we can usually do very short courses of treatment that have lasting effect. And then there's a lot of different Rituximab-based combinations or treatments, and we'll talk a bit about that. So when we're talking about gastric extranodal marginal zone lymphoma, again, we talked about that H. pylori infection. So this is actually a picture on the right of what that infection looks like. So you can see it's got this whip-like tail. It's very endemic in parts of the world, and it can cause all these different illnesses. Not only mole lymphoma, it also increases the risk for gastric cancer and can cause kind of chronic inflammation. So in patients that have this infection, we know that actually if we treat their infection with what's called eradication, which is usually 3 different medications taken for 10 to 14 days, actually 70 to 80% of lymphomas will go away with just removing that infection. So removing that sort of constant stimulus or causative agent. That can happen very slowly. So sometimes it can take up to 12 months to see the lymphoma go away. And so what's happening is that we're repeating scopes, usually every 3 months, just looking to make sure that the lymphoma is receding. We can also repeat assessment with a breath test to make sure that that H. pylori infection is gone, because sometimes it takes multiple courses of treatment to make sure it goes away altogether. We do know that some individuals do not harbor that H. pylori infection, and we still actually will even try eradication in some of them, because there can be what's called false negatives, where we know that, doing a bunch of samples of the stomach doesn't always capture all the bacteria that's living in it. So a lot of times we'll try eradication even if they are H. pylori negative. However, if we see this one mutation, we know that there's a much higher chance that they will not have a remission with eradication. So what you can see is that in those patients that did have the mutation, only 10% of them responded, compared to those patients who didn't have the mutation, where 74% of them responded. So we will stratify patients a bit by whether they have an H. pylori infection and if they have the high risk of mutation. So if they have several of these features, or we're not seeing that they're responding to eradication, the next step at that point is to move on to radiation. So this is called involved site radiotherapy, which is where we just radiate the stomach and some of the lymph nodes that are in very close contact. We know that that's extremely effective. So the remission and cure rate is very high, over 90%, and only 5 to 10% of people will relapse over time. So very, very effective therapy for this lymphoma. And sometimes, again, eradication alone is enough. So when we talk about hepatitis C, this is the most common infection that we'll see frequently in splenic marginal zone lymphoma. So because we have highly effective, well-tolerated therapy for hepatitis C now, as of, I think, the past 5 to 10 years, this should be strongly considered anyway in anyone who has a chronic hepatitis C infection. A lot of them will have mild liver disease, so there's an indication anyway for clearance. We know that in people who have a persistent infection that's not cleared, they have a 7 times increased risk of developing marginal zone lymphoma. And similar to the H. pylori story, if they have treatment of the virus and they clear it, actually 70% of the time, the marginal zone lymphoma will go away on its own, because again, we're removing that kind of causative or driving agent. There's other reasons to clear hepatitis C, such as fibrosis, cirrhosis, etc. So just a really good conversation to be having with people. And there's actually specific screening guidelines for family medicine practitioners for who they should screen for hepatitis C, just because we do know that it can be associated with these various conditions. So talking about radiation again, it's very commonly used in extranodal marginal zone lymphoma, or if people have limited stage disease. The recommended dose is 24 gray, which essentially usually translates to about 12 days of radiation. So this isn't, something that we expect to be going on for weeks and weeks and months. Rarely, if people are symptomatic but don't want to go through that many days, we'll do actually only 2 days of radiation. But we do know that there's a higher risk of relapse. So again, the preference is for a bit more radiation than that. This is generally very well tolerated. There are some potential complications, however, and that's very much dependent on where the actual lymphoma is. So we can sometimes get dry mouth if we're radiating the saliva glands, hypothyroidism if we're radiating the thyroid gland. You can get cataracts or dry eyes, which can sometimes be worse if people already have an autoimmune condition that causes dry eyes, such as Sjogren's syndrome. So some people really feel that they can't tolerate radiation. or it's not felt by their physician to be the right choice. So in that situation, we'll sometimes use what's called single agent rituximab. So rituximab is an antibody that's directed against a protein on the surface of the lymphoma cells. And we'll talk about it a little bit later. There is a high response rate. So usually it's about 60 to 80% of people will respond to single agent rituximab. However, we do know that there's a high relapse rate when we use just that alone. So it's usually the average is people have about 15 to 20 months. And at that point, kind of 1 to 2/3 will relapse. So it is a consideration, just certainly not our preference for these limited stage patients who we know can have a very long disease-free survival after frontline treatment. So when we're talking about advanced stage disease, again, we think that this is not a curable type of cancer, but it is a very treatable type of cancer. So as I mentioned, watchful waiting or active surveillance is a very accepted strategy if patients are asymptomatic, because again, we just give them the side effects of chemotherapy and we're not actually extending their life. So when we do decide to treat patients, the goal is alleviating symptoms and improving their quality of life. So what are indications for treatment? So there's actually criteria that were built more for follicular lymphoma, but we apply them to patients with advanced stage marginal zone. And so that can include if they have low blood counts, either from a very large spleen or from extensive bone marrow involvement, if they're symptomatic from a large spleen or lymph nodes, or if they're having those other symptoms like fevers, weight loss, or sweats, then we'll think about going ahead with treatment. So there's a couple different scenarios that I'll talk about that are specific to subtypes. So the first one is for splenic marginal zone lymphoma. So we used to take out spleens all the time before we realized that maybe there were some kind of downsides to taking out spleens. But this can actually be an effective treatment for splenic marginal zone lymphoma specifically. So BC published their experience from 1985 to 2012, looking at 107 patients with splenic marginal zone. You can see most of them had stage 4 disease, and obviously most of them had splenomegaly. They looked at their initial treatment. So again, this was sort of taking a backwards glance. So it wasn't like they were enrolling them on a study and randomizing them to, different arms so that we could compare between the two. But essentially they had 52 patients who received splenectomy, 38 received chemotherapy, most in combination with rituximab, 2 received antivirals for hepatitis C, and 15 were observed. I should comment that, again, this, like the other types of indolent lymphomas, can sometimes turn into what's called large cell lymphoma, which is an aggressive lymphoma. So that happens, in a small percentage each year. So in this study, they noted that they saw transformation to that large cell in about 18% of 10 years. So just, it's a small percentage, but it is something that we keep in mind when patients become symptomatic. And so what you can see, and these are those curves that I talked about, is that those patients with splenectomy actually did better than those receiving chemotherapy, both in their overall survival, but also in the what's called failure-free survival, which is essentially that they haven't failed their frontline treatment, that they're kind of categorized according to. I will say that, the average age in this population was 67, but there were patients up to 88 years. So when we talk about survival, if you look at the x-axis here, it's out to 25 years. So it's not surprising if they had patients up to 88 years that there's actually going to be people passing away from other causes. So this is actually quite good survival when we're talking about sort of a 25-year timeline. But we do see, again, to summarize, that splenectomy seemed to be quite effective compared to chemotherapy in this population. However, there's lots of issues with splenectomy. So again, we used to take them out kind of willy-nilly for all different types of lymphoma, but then we realized that these patients actually were frequently getting infections after the initial surgery. They could have extensive bleeding because it's this sort of big blood-filled organ that you're taking out that's frequently quite large. They try to do it through keyhole or laparoscopic, but sometimes have to convert to open, so that there can be a sort of long post-surgical recovery. We know that they have an increased risk of clots, or thrombosis. And part of that is that the spleen's job is to help clean up the older cells. And so if you take that out, people's counts can be a bit higher and they can have sort of this more pro-clotting phenotype. And then specifically because the spleen is part of the lymphoid tissue, there's specific bacteria that are called encapsulated that the spleen really helps to fight off. So they're kind of beyond our regular immune system defenses. So they really need that spleen help to help fight them off. So there can be long-term immunodeficiency that patients develop against these specific bacteria. So it's extremely important that patients who are getting their spleen removed have these different vaccinations. And I just listed on the right the different vaccinations individuals need to receive. So some of them, there's multiple boosters over time, but essentially that's all to kind of try and take the place of the spleen in fighting off infection. So what about rituximab? So like I said, this is an antibody that was developed kind of more than 20 years ago. And so this is essentially, this is more of an immune treatment. So it's an antibody and it's targeted against a specific protein on the surface of the cells. And so all cells have different proteins. That's how we tell exactly what type of lymphoma it is. So what happens is that this antibody comes along and it sticks onto the protein on the surface of the cells. And it actually signals to other cells in the body that lymphoma cell shouldn't be there. So it causes the body to attack the lymphoma cells. It causes them to release different things that can actually kill the cells in different ways. So this is kind of the first, or one of the first really targeted medications that we had to treat lymphoma. And this has made a huge difference when we look at how people do with B-cell lymphoma compared to T-cell lymphoma, where we don't have sort of a standard antibody that we can use in all different types of lymphoma. So there are some side effects from it. People can have infusion reactions or sort of they can have allergic responses when they get it. Usually it's with the first treatment. They can get infections from it because you're knocking down not only the lymphoma cells, but also some of their normal white blood cells. And they can also get very rarely trouble with their lungs. The thing that we worry most about with rituximab is actually that because we're attacking your not only your lymphoma B cells, but also your normal B cells, those are what we use to respond to vaccines and infections. So during the time of COVID, it's been very challenging to decide what to do with people's rituximab dosing, since we know that it can affect their ability to mount a response to the vaccine. So just something to talk about with your physician regarding timing of rituximab vaccine doses and things like that. So, recognizing all these issues that taking the spleen out presents, we started to wonder whether we could use rituximab alone for this very kind of slow-growing lymphoma, so splenic marginal zone lymphoma. So in this study, they looked at 85 patients total, and the majority of them got rituximab weekly for 6 doses, and then rituximab every 2 months afterwards. Which is called rituximab maintenance. So there's sort of like that initial build-up phase where you're getting lots of doses of rituximab to get it built up in your system. And then after time, we try to maintain responses. So they found that the response rate to just rituximab on its own was 95%. Normally that response occurred within 2 to 3 weeks. So you're seeing the shrinking of the spleen, improvement of the blood counts, and repeatedly exposing individuals to maintenance over time improved their long-term control, which is sort of not surprising. So giving them a little bit of rituximab just to kind of keep things in check. This was better than the response rate to splenectomy. So they saw an improvement, and actually those splenectomy numbers are better than the BC series, which might also be accounting for kind of better supportive care over time when you look at the timeline. And again, this is just those Kaplan-Meier curves or the charts that we look at, looking at progression-free survival. So that's being alive without the lymphoma progressing or having a relapse. And you can see that for both that and overall survival, rituximab was superior to splenectomy. Overall, these individuals did very well. And again, very long time frames. So we're looking at 20 years at the bottom. So if individuals are needing chemotherapy, so they have more sort of advanced disease, then we think about chemotherapy usually in combination with rituximab. So these are the options that we think about. So R-CHOP and RCBP are sort of more classic chemotherapies. We've been using BR pretty standardly frontline. So if anyone has been treated recently, they most likely received BR. And then there's other sort of combinations that we think about for more frail individuals, which include lenalidomide plus rituximab, which is called R squared, or chlorambucil plus rituximab. I should mention that there's large variation in funding according to provinces. So, you know, my experience predominantly has been in the Ontario cancer system, so that might be a bit different from your own province. So, you know, originally we were using what's called R-CHOP and RCBP, but then there was interest in this drug called bendamustine. So there were actually two very big studies. One was done in Europe and one was done in the Americas and Australia, comparing bendamustine and rituximab to this classic R-CHOP. So when we talk about R-CHOP, it is very effective therapy, but it does result in sort of the common things that we think about with chemotherapy, like hair loss, numbness in the fingers and toes, mouth sores, nausea, etc. So the question was, is there a different combination that we can use that will have a high response rate and will have less of those toxicities when we think about sort of a slower growing lymphoma where we don't necessarily need it to hit it as hard and fast as we were doing with, for instance, R-CHOP before. And so this study looked at all indolent or slow growing lymphomas. And what they saw was that the response rate, again, it's the red line, this is specific to marginal zone lymphoma patients. The response rate was 93% in all patients. So that's all patients with indolent lymphoma. There was a higher complete remission rate compared to the R-CHOP arm, but the most important thing that we saw was that they had less of those toxicities, so less hair loss, numbness, mouth sores, infections, and sepsis episodes. We did, however, see that there are more skin reactions. So it's more common for people to have hypersensitivity, bad skin rashes, or things like that, in which case we would think about switching to an alternative regimen. But overall, very excellent response rates, and these lasted for years and years. Frequently, the average was approximately 60 months. Again, this is the same sort of study that was done, but again, in the Americas and Australia. And here I just want to point out that when you look at complete remission and partial response, so that would be considered responders, it's 92% for patients with marginal zone lymphoma. So again, over 90%. Very good. There was another study that specifically looked at splenic marginal zone lymphoma, showing a response rate of 91%. And at 3 years, most patients did not require further treatment. So we know that patients have a very, very good response when we do start chemotherapy on average. So there's sort of more interest recently in chemotherapy-free approaches. So there's a combination called R squared, which unfortunately is not funded in Ontario, but may be funded in other provinces. So this is a combination of pills, which is the lenalidomide and IV rituximab. And so it's the lenalidomide is considered an immune modulatory agent, and the rituximab is an antibody. So this is given for 6 to 12 cycles. Generally, each cycle is 28 days, so it's pills for 21 days and an IV treatment. And we see that there's responses in, again, over 90% of patients, lasting on average 60 months. I will say that there's kind of other side effects. So just because it's an immune treatment doesn't unfortunately mean that it's side effect free. So the lenalidomide can cause issues like diarrhea, leg cramping, low blood counts. There is a slight chance of blood clots that can occur with it. And we also are concerned about secondary malignancies. So I think this is why this has not been kind of as well studied as bendamustine and rituximab, which mainly remains our first choice for treating patients. But this is definitely an option and is widely used in other areas like the US. So when we talk about maintenance, so there's kind of what I call the workhorse period at the beginning, where people are getting a combination of chemotherapy and rituximab, or they're getting rituximab weekly. So that's sort of the buildup initially to debulk the lymphoma. So lots of therapy all at once. And then once we get rid of as many lymphoma cells as we can, we want to maintain their response. And so that usually involves giving rituximab every 2 or 3 months for, generally it's funded for 2 years within Canada. And what we know is that this will sometimes deepen a response. So if patients didn't have a great response, sometimes they can go into a deeper response over time, or it sort of extends the period until their lymphoma will come back. So they have more time until their next treatment. The trade-off is that they're still on therapy, but generally it's quite innocuous. So individuals will come and see us, every 3 months. They'll, for their regular checkup anyway, and they'll just get an injection the next day, usually under the skin. So looking at marginal zone lymphoma, in the one study that was done in Europe, they looked at 2 years of rituximab every 2 months versus observation, and they did see that those receiving maintenance were in remission significantly longer, so they didn't have recurrence of their disease for a longer period of time. But I will say that those who did not receive maintenance still were in remission for more than 7.5 years. So, there's different kind of conflicting opinions on the value of rituximab maintenance. Again, there are downsides like infection risk, especially in the landscape of COVID. But I think that's an individualized choice to make with your physician. There's also a question about whether instead of doing maintenance, so keeping people on treatment, or just actually reserving the rituximab for retreating them when the lymphoma comes back. And so there's a study called the RESORT trial that looked at whether it was better to keep people on rituximab and prevent the relapses, or just to treat them with the rituximab when it came back. And I guess not really surprisingly, those people who were on maintenance, their remission lasted longer, but interestingly, that didn't translate to them living longer. So what that says is that even though the lymphoma is relapsing sooner in those who didn't receive maintenance, it doesn't actually translate into them living longer. So it's probably reasonable to just think about retreating them when the disease comes back. I should mention that in this study, they sort of did indefinite rituximab maintenance, whereas in Canada, based on other studies, it's only funded usually for 2 years. So when we've, completed this frontline therapy and we're assessing response and doing follow-up, so at the end of treatment, we are frequently doing CT scans, so making sure that, the disease is all gone, or seeing if they have a partial remission or complete remission. Rarely we'll use PET scans at this point. We'd be seeing patients and doing regular history, physical exam, and blood work. So we're frequently seeing people initially every 3 months, and then every 6 to 12 months if they're stable for several years. And then, it's again, there's a lot of variety with marginal zone lymphoma. So there's a lot of, differences on how you're going to follow them up, especially if they have those extra nodal sites. So for instance, a lot of times we'll make recommendations for the gastroenterologist to repeat endoscopies, initially every 3 to 6 months, and then potentially yearly to look for recurrence. Sometimes individuals need follow-up MRI of their head, neck, and orbits, thyroid ultrasound, mammography, and breast ultrasound, and that can sort of be coordinated with regular screening practices. And then also some of these individuals will be followed by dermatology, who actually can do full body photos now with really complex software. And so, we have all these different kind of treatment patterns, and what we do when we're thinking about the patient in front of us is that we gather all the information. Again, we can use the staging and those prognostic indexes or calculators, and then we can decide on what the best step is. So again, the goal with marginal zone is that because this is frequently slow growing, it doesn't make sense to give people a lot of toxic treatment up front to try and get them into a remission, because we know that actually sort of more gentle treatment can result in long remissions, and that these individuals usually live for kind of a very long time. So we don't want to have them, very unwell with lots of side effects from very strong treatment when we can sort of use more moderate treatment. And so we'll use all that information to build into algorithms. So this is just an example of one that we would use, looking at malt lymphoma. So we have either gastric or non-gastric. You can see we're considering their staging, whether they have that H. pylori infection, and we can use that to decide on the most appropriate treatment moving forward. If they need systemic treatment, again, we're talking about chemoimmunotherapy. We don't really frequently use this radioimmunotherapy. It's hard to access in Canada, and also it does have significant side effects that I won't go into. And then if they're relapsing after that, we have some different options in consideration of the clinical trial. So speaking more to treatment and relapse, so it's important to remember that part of why we don't do routine kind of follow-up scans is that even if we saw, for instance, an increase in a lymph node from 1 to 2 centimeters, if the person in front of us is not having any symptoms, technically they've relapsed based on that CT scan, but there's not really an indication to treat them. So it may be that even at the time of progression, individuals can go for further years before they need treatment again. So it's always just sort of assessing, do we actually need to intervene at this point? Similar to that study that I talked about, the resort trial, there's, you can retreat them sometimes with what they received the first time. You can use other frontline options or consideration for a single agent Rituximab. And if all of those things are not effective or not an option, then we can think about emerging or novel therapies. So my comment for this is that most studies of indolent lymphoma are in patients with follicular lymphoma, just because that's the largest subgroup of indolent lymphoma patients, or it includes all indolent lymphomas. So a lot of the data that we have for other types is really extrapolated from those patients with indolent lymphoma. We do have some studies where marginal zone lymphoma patients were included, but it's hard to have really specific and firm guidelines about what to use in second line because we sort of don't have all the data that we would wish. So I've just included in a list here various things that have been studied, and I'll just briefly mention. So obinutuzumab is another antibody, so it's sort of the same but different from rituximab. So that's in patients who are either refractory, so no longer responding to rituximab or have been exposed to it before. Sometimes we can give them this obinutuzumab, which is targeted against the same protein on the lymphoma cells, sometimes in combination with other chemotherapy, and we can still get a response in those individuals. There are medications that end in inib, so ibrutinib and zanubrutinib. These are called BTK inhibitors, so they sort of are pills that affect a different signaling pathway within the B cells, and we can see that response rates can be up to 50 to 60% in these individuals. Copanlisib is something called a PI3 kinase inhibitor, so if there's individuals watching who have had marginal zone lymphoma or know someone with marginal zone lymphoma that have been treated for a long time, they may have received other members of this family like idelalisib. Those are less commonly used now or not available. So the most common one now used is copanlisib. You can see it has a response rate of almost 80% and does have a long response. So progression-free survival was 24 months in a very small study of these patients. There's also that R-squared combination, which we know is effective in the second line. It is a consideration, especially if patients are interested in a chemotherapy-free approach. And rarely we would use bortezomib, which again has a response rate of 60%, though a low CR rate. So the biggest barrier, unfortunately, to accessing these medications is access. So a lot of these medications, because they're, again, small subgroups of larger studies, are not funded. So just because something's FDA approved doesn't actually mean that it's funded within Canada or within your province. So it's really important if you have any questions or concerns, or if your disease is progressing, to ask your hematologist or oncologist if there's any clinical trials options. We can also access some of these medications through compassionate programs where we are given the medication for free to use in patients. So that might be a good option for certain individuals. So a rare event that can sometimes happen in marginal zone lymphoma and that we get quite concerned about is a transformation to aggressive lymphoma. So I've mentioned it a couple times. Essentially, this is where, further genetic changes happen within the lymphoma, where it starts to, the cells look bigger and nastier. They start to grow faster. They can spread to more unusual places. So this can happen in about 5 to 10% of cases, sometimes up to 15% in long case series over time. Usually the symptoms, it doesn't behave like we would expect marginal zone lymphoma to behave. So one area is growing faster or it's bulky. Patients are having much worse symptoms than we would expect. Blood tests are changing, such as the high LDH, which is a marker of cell turnover. Or if we were prompted by symptoms, we might perform a PET scan, which might show an area that was a lot more hot or avid than other areas. So if we're concerned about this, we would repeat a biopsy, and you can actually see on the biopsy that there's a conversion with, the cells having these more aggressive changes noted. This is associated with hepatitis C in about 25% of cases, and this is a situation where we would consider immediate, stronger chemotherapy. We would sometimes think about stem cell transplant with a patient's own cells, so that's called autologous transplant, which we use actually very rarely in marginal zone. And there's also a treatment called CAR-T, which we're not funded for marginal zone alone, but we could consider if there was transformation to aggressive lymphoma and the patient has received multiple treatments and is still progressing. So there's still lots of unanswered questions that we can guess at, or we can hope we know the answer to, but that definitely deserve more study. So for instance, a question I get asked a lot is how often we should be scoping gastric extranodal marginal zone lymphomas. So there's not really a good guideline that says if you scope this often, you're going to prevent this, and this is worth, the risks with each procedure. So it's kind of a gray zone, and part of it is availability of our gastroenterology colleagues. But generally it's kind of more frequent initially, so every 3 to 6 months. There's some guidelines that recommend yearly after that, but actually we know that the relapse rate is actually quite low, especially if patients have received radiation. So then it's kind of, it's hard to justify indefinite scopes, especially for younger individuals. So again, it's a conversation. Again, as I discussed, there's some controversy regarding the usage of PET scans. So we still don't know, when the best situation is for using a PET scan for monitoring or assessing response. And there's definitely new techniques within PET scanning that are optimizing them so that this lymphoma may be better staged by those in the future. And then certainly effective and well-tolerated therapies in relapse are crucial importance. And so hopefully more studies focused on specifically marginal zone lymphoma patients, or including large numbers of these patients in their study design. So to summarize, marginal zone lymphomas, they're associated with chronic infection and inflammation. I mean, as you've seen, there's lots of variety in how they present, their location, their symptoms that they cause. They're frequently slow growing with long survival, but we do know that they relapse over time. Response rates are very high to whatever, frontline treatment we're considering. And the goal is minimizing toxicities because of that kind of long survival and the trajectory that these patients have. Thank you for your attention, and I look forward to your questions in the Q&A.
Thank you, Dr. Davies, for your excellent presentation. We appreciate your thorough review of marginal zone lymphoma, detailing diagnosis, prognosis, and treatment options available for Canadians. I would now like to direct our audience members to attend the live Q&A session following this presentation. Thanks, everyone.